Gynecologic carcinosarcomas are rare aggressive tumors primarily of the uterus, while hepatopancreatobiliary or HPB surgeries, which involve the liver, pancreas, and bile ducts, are considered moderately common to rare depending on the specific procedure. Work being done at the OSF Cancer Institute is being done to improve the outcomes of those facing these diagnoses.
We are doing high volumes of these complex surgeries, and people sometimes ask me, like, how much of this do you do? Which is a good question for a patient to ask and an important question to ask. But we're doing as high level care as you here in Peoria as you're going to get anywhere.
That's Dr. Chandler Wilfong, a cancer surgeon, and I'm Shelli Dankoff, your host for OSF HealthCare Accelerated. We appreciate you tuning in and remind you to be sure to subscribe, rate, and review wherever you get your podcast. Our hope with OSF HealthCare Accelerated is to give you a look inside our journey to transform healthcare and the solutions we're piloting to solve health obstacles. Today we are focusing on gynecologic carcinosarcomas as well as hepatopancreatobiliary or HPB surgery. Our conversation takes a look at how OSF is improving treatment for these rare conditions and what we bring to the table in that space. Joining us are Dr. Michelle Rowland, a gynecologic oncologist, and Dr. Chandler Wilfong, a surgeon who focuses on liver, pancreas, and bile duct cancer surgery. Thank you both for making time in what I know are very busy schedules to be with us. First of all, Dr. Rowland, I'm going to start with you. So, gynecologic carcinosarcomas, what exactly is that and how is it typically treated?
Yeah, so carcinosarcoma is a very interesting group of cancers, and it can come from the ovary or the uterus. But basically, it has both characteristics of sarcomas, which are muscle tumors, and things like the epithelial cells of the ovary or the uterus. So because of that, it can, at different times, take on characteristics of both of those agents and be a little bit more challenging to treat because of that wide variability in the tumors.
So how do you even diagnose it? I have to believe it could look like different things and not present as, oh, this is it out the gate. How do you diagnose?
Yeah, so most of the time we're diagnosing them similar to a typical endometrial cancer and ovarian cancer. Symptoms that may come up that show us that somebody has a mass, for example, of the ovary. They've got bloating, abdominal pain. They may actually feel a mass. Or in the case of endometrial cancer, oftentimes people will have vaginal bleeding. So those are definitely things that we encourage patients to bring up to their provider, and then we would start a workup.
So what's a typical course of treatment?
Yeah, so typically for these, we use all of our tools if we can. We're looking at using surgery, radiation, chemotherapy, immunotherapy, and targeted agents, depending on what we can learn about the tumor. And that's kind of, I think, the most exciting part these days is that we're working with a number of providers across the country trying to really specify how we would treat someone with carcinosarcoma. What tools do we use at what time? How do we use them? Which chemo agents? Which targeted agents? And that's where we're trying to put all our brains together.
And I want to come back to that collaborative efforts, but I'm going to bring Dr. Wilfong into the conversation. So HPBs, what your scope of what you treat, and I think we're getting more attention these days because, there's been a lot of attention around colorectal cancer. We've had some high-profile deaths around that, James Van Der Beek, Catherine O'Hara, and then even pancreatic cancers out there. So let's talk a little bit about what conditions you treat regularly.
Yeah, so we treat a pretty large spectrum of, benign and cancerous problems involving the stomach, liver, gallbladder, pancreas, and bile ducts. So that from a cancer side of things, we treat a lot of colon and rectal cancer that has spread to the liver, and we treat cancers that start in the stomach and pancreas and bile ducts and also the liver. And, that covers a wide range of operations and other non-surgical treatments too.
I feel like, and maybe it's just me, but we've been hearing an increased incidence of all of these cancers that you're talking about. Is that my imagination, or are there a lot more cases of especially colorectal and pancreatic cancer being diagnosed these days?
Yeah, it's not your imagination at all. And we're seeing, if you look at pancreatic cancer, it's the third leading cause of cancer deaths in the United States year after year, increasing. We're seeing more and more cases every year, actually. It's increasing in incidence. And colon rectal cancer is also an increasing in incidence. And, it is one of the more preventable cancers that we have, which is why everybody should get their colonoscopies. And even as we see an increase in non-colonoscopy tests like Cologuard, and now there's a blood test, for low-risk patients, that's okay. But if you have family histories or have polyps, those things are not going to be a good substitute.
From your perspective as a cancer surgeon, is that concerning to you, seeing this increase in these incidents and especially in younger people? These aren't, your 70, 80-year-olds. These are younger people who are being diagnosed.
Yeah, it is very concerning, and certainly we more often than not see this in older patients. It's more common in older patients. But the incidence is rising in the young patient populations, especially in that 40 to 50-year age range. And I don't think we have a good handle on why that is.
At the OSF Cancer Institute, one of the things that, in addition to just increasing the number of specialty providers and growing the home, bringing people here so that they can receive treatment for a wide variety of cancers, clinical trials. Let's talk about, in both of your worlds, some of the clinical trials that are going on and some of those other collaborative efforts that are taking place across the country.
Yeah. We're really working in GYN cancers to really expound upon our clinical trials. For many years, really, unless people traveled, those weren't options. And so we're very happy. In the past couple of years, we've actually been able to open up really across the board, cervix cancer, ovary cancer, endometrial cancer trials, and a number of different very important questions that people have. It may be as simple as, hey, I finished my therapy and I don't have any evidence of disease, but can you offer me anything? We have trials for those people, or people who may have had a few lines of chemotherapy and they're looking to try something that's new that maybe is targeted to specific parts of their tumor. And so we're able to offer those and keep them in the area so they can get their care locally and still have their local supports.
Yeah, I think the gynec folks have really, pioneered our clinical trial programs. And, our focus right now is on early detection. So we have a couple of National Cancer Institute trials looking at what's usually called a liquid biopsy, which means how can we develop a blood test to screen people for pancreatic cancer? And we aren't there yet, but that's our goal long term. And then we're also going to move on to hopefully some new drug trials for pancreatic cancers, as we're starting to see more targeted therapies become approved for pancreatic cancers, which is in that realm new.
Is that one of those, again, it's a great resource at the OSF Cancer Institute in Peoria, Illinois, to have those resources here. And you made mention of it, not having to travel to maybe bigger cities, because there's a certain comfort level as well in a community like ours for a lot of the patients that we see. And once they have that comfort, but just to have those resources here, what does that mean to you as physicians to have those at your disposal?
Yeah, I think in GYN, most of our trials are cooperative group trials. So they run across the country at a number of different institutes because most of our cancers are rare. So if you try to do a trial at one site or two sites, you would take too long to do it. And so it really brings the best of the science to people here. So we do have some investigator-initiated trials in carcinosarcoma that we're trying to open as well, but most of ours, it's really bringing something that they would have had to go to MD Anderson or Chicago or St. Louis, just depending on the trial to get, and now they can be involved in those cooperative group trials and still maintain their care here with us.
And there's something to be said about just the ease of care.
Yes.
Because for the mental status even, just the emotional and the support systems that exist, I think that's another big part for patient care, isn't it?
Yeah, it's actually really important for our area because we cover a large geographical region, right? And if you look at, the focus on rural cancer care, which outside of the city of Peoria, the vast majority of our coverage area is rural. And there's a worse outcome for patients in rural areas with cancer. That's clear. And there's a lot of reasons for that. And you could spend an hour talking about that, but access is one of the big problems. So if we can deliver, world-class trials locally, that's very important.
Yeah, and I think just one other point along those lines is that most of those studies show they're underrepresented in minority groups as well as people in rural areas. So when we're getting that data and the results from them, we don't know if it applies. So having those patients included is also really important.
Yeah, there's something to be said about just the ease of access in a Peoria. You're never going to completely reduce the fear when you're going in to be treated for cancer, let's be honest. But if you can come into a more smaller setting, if you will, but it's a big town with the smaller setting feel, and I'm sure that's very helpful to your patients. So what kind of things are on the horizon that you are working on that get you excited on a daily basis?
Yeah, I think, in the carcinosarcoma space particularly, we are working with a couple of different physicians throughout the country trying to not only improve clinical trials here, and we have an investigator-initiated trial that we are working on opening that was started by one of what I would consider the probably most involved investigators in carcinosarcoma. So we're excited to offer that, but also to bring our knowledge across the country to people about treating these rare tumors, because it's very challenging to have 1 or 2, 3 patients a year with a rare cancer, maybe even less than that. Some people may only see 1 in 5 years, and yet they may need care locally where they are. And so we are working to also provide support to people throughout the country and give them our expertise as well.
How about in your world?
Well, our goal is to expand the access for patients to get complex cancer care in Peoria. So that involves a lot of things that we have, but we want to expand them and offer new things like medical oncology drug trials and things that we've had less access to before. So we're doing more complex surgery every year, and these are things that patients would have previously traveled for, even, if you look 10 years ago. So we want to expand the access to complex cancer care as much as we can.
Yeah, I think there's less and less every day that we can say we can't do, that we can't go down the hall and talk to someone in another discipline and put something together that's a complex surgery or complex radiation plan and get those done here.
Yeah, because both of you deal with can be challenging populations of people who are facing very difficult diagnoses. So is that what drives the work you do, is knowing some of this collaboration, some of these other things that are coming that to help meet those challenges? Does that help you as physicians on a daily basis?
Yeah, I think, every day we care about each patient that we see. So being able to bring them what we think is a comprehensive plan and the best tools is a very rewarding thing. And I think it's a changing landscape every day. And so being able to have access to a cancer institute that wants to meet those needs helps the patients.
Yeah, everybody always says it takes a village, right? And, we may think of ourselves as the, pillar of treating a cancer diagnosis, but that's not necessarily true. We're an important part, but we have nurse navigators, social workers, financial navigators, nutritionists, dietitians. The list goes on and on. We have grants with the American Cancer Society, and it's a web of support for every patient, and it takes a lot to treat these long-term disease process like this. And if you think about in a perfect world, these patients are getting cancer treatment for at least a year, and it takes a lot of support to hold our patients up.
Yeah, so that's very important. You're right. Thank you for bringing up the multidisciplinary, because that is huge. Mm-hmm. What is your message? Again, we've touched on the fact that younger people are being diagnosed. Everybody wishes there was a magic pill and I could find out in the way I'm going to prevent it. But right now, we don't know what that is on how to prevent these things. So what's your message to people about maybe trying to stay cancer-free? Or maybe some of it is just the luck of the genetics draw. We don't have clear answers, do we?
There aren't clear answers. There are some things that are obvious, right? If you know that you're high risk because you have family history, talk to your doctor about it. Get screened when you're supposed to get screened. Get your mammograms and your pap smears and colonoscopies. They work. And, there are modifiable things you can do too. We see less smoking as time goes on, but that's a big risk factor for most cancers.
Yeah. And the young age. I think sometimes younger people seem to think they're invincible. So don't think just because you're not of a certain age.
Yeah, and I think there's being in touch with something doesn't seem right and advocating for yourself. And, as much as we as physicians or nurses, all the people in our system want to make early detection, some of it is just being aware of that and really going back. And if you don't get the right answer the first time, come back. Hey, I still don't feel like something is right. Let's talk about that. Let's look at that because somebody might not be thinking. We used to think gynecologic cancers, like I went into that because we take care of older ladies. Well, sometimes we don't anymore. We do have younger people. And so, your primary care may not first have that on their mind. But if you bring it up a couple times, maybe you get the right testing.
Yeah. My primary care, I love her because she just is like, being not too grave, she's like, if you see blood in certain places, you come see me. I'm like, okay, that's great. She's very direct about it.
Yeah.
I love providers that are very clear. This should not be happening.
Yeah.
And we should all check in with our primary cares because goodness knows I hadn't seen one in years.
Yeah. They are really our frontline soldiers, if you want, in terms of finding cancers, preventing cancers. It's not us. We work with them to try to get good screening rates and things like that. But I think having a good relationship with your primary care and seeing them can find things.
Yeah, they keep track of those things. Okay, from year to year, this has happened, that hasn't. And some of it is the natural aging process. Yeah, it stinks some days. And I'm like, why is that hurting now? But is this normal? To your point, is this normal? Ask the questions. Yeah. Anything else we haven't touched on that you think is important for people to know about some of the work going on in your areas or other things coming down the road?
I think from an HPB standpoint, as we always call it, what I like to consider ourselves here is, we are doing high volumes of these complex surgeries. And, people sometimes ask me, like, how much of this do you do? Which is a good question for a patient to ask and an important question to ask. But, we're doing as high level care as you here in Peoria as you're going to get anywhere.
Yeah, and I think if you have ongoing cancer care, it's always reasonable to ask, are there trials available? Is there something new I should try? Because it is changing all the time, and there may be a new opportunity.
Well, Dr. Michelle Rowland, Dr. Chandler Wilfong, again, thank you for taking time to speak with us today and bringing us up to date on what is going on at the OSF Cancer Institute. We will put the number for the Cancer Institute in the line notes for this podcast. That's the other beautiful thing. If you think you even have a question, just call, and there are people to talk you through, and you can ask questions, and they can get you to see the best people. So thank you for joining us for this episode of OSF HealthCare Accelerated. And remember, you can find all past episodes online at osfhealthcare.org/accelerated.